9, 8, 7, 6, 5, 4, 3, 2, 1. Am I live now?
Yes.
So good evening, ladies and gentlemen. Salam alaikum. My name is Devasita Bhattacharya. I represent Abbott CRM, and decoding arrhythmias means to that the name of the topic says how interesting it's going to be. I have with me entire Bangladesh senior faculties, senior professor, and all of you. Extremely humbled to join here with me. Couple of international faculties are there. For them, it's a good morning, depending upon the time. Now I would request Dr. Professor Atahar Ali to say something about this particular group name, because it is interesting, as you know, ECG study group. What is the reason for this group, and how this group, what is the expectation for the program? So please, Dr. Atahar Ali.
Good evening, dear participants, honorable faculties, Dr. Abhishek Deshmukh and Dr. Rafique Ahmed from USA, our honorable panelists, particularly Professor Nuzrul Islam, our teacher, Professor Shajol Banerjee, Professor Zakir Hossain, Professor Mahbub Rahman, and Arun Maskir from Nepal, and I think many others also have joined. Those who are already joined, I welcome everybody. And it is my privilege to introduce the ECG study group. So just introduction, brief introduction about the ECG study group. So what is it? It is a platform for ECG learning, and this group is working for more than 5 years in this country. The course directors of this program, me, Professor M. Atahar Ali, and Professor Abdul Wadud Chowdhury. I am working as the consultant electrophysiologist and heart failure specialist at Evercare Hospital, Dhaka. Previously, I worked as Professor of Cardiology at NICDB, Dhaka. My special field of interests are ECG, electrophysiology, and heart failure. And Professor Abdul Wadud Chowdhury is the professor and head of cardiology at Dhaka Medical College. He is the renowned clinical and interventional cardiologist. He is very popular and well known for his own art of teaching. He is a dedicated teacher and trainer. His special field of interest, ECG, teaching, and cardiac intervention. He is the first person to think about this study group. And we are very much happy to announce that our international advisor is Dr. Rafique Ahmed, an internationally popular electrophysiologist, a great teacher, and today is one of the faculty. He is honored for his pioneering role in foundation of electrophysiology in Bangladesh. We are grateful to him. And the target participant of this program always our students, those who we actually love, our residents, fellows of cardiology, internal medicine, and critical care medicine, and anyone who are interested in learning the ECG. And our faculties are actually me, Professor Abdul Wadud Chowdhury, and Dr. Rafique Ahmed. But most of the time, we also include some renowned faculties from home and abroad. Our activities are actually, we are doing the 4 activities. ECG Fiesta. Actually, this is the interactive ECG class. We arrange this program all over the country, the big cities or the medical colleges. This is one of the program. That is another popular program, which is called the online teaching course. This is the that is the course that is dedicated to teach the students, or that is the trainers, that is the residents, the full course of the ECG we are to teach them. That is the online ECG course. Then online ECG reporting course. This is another course that is going to be started, and it will be actually moderated by our Dr. Rafique Ahmed. That will be another course in the Facebook, and another Facebook ECG discussion forum. So these are the activities. So ECG study group is a very dedicated, actually totally a learning forum where we can share our expertise experience, teaching, learning everything about the ECG in this forum. So this is all about the ECG study group. So with this, I like to conclude about the ECG study group, and I like to request Professor Abdul Wadud Chowdhury to introduce our faculties. Dr. Devasrito, Mr. Devasrito.
Yes, I would request Professor Wadud, please introduce both of our speakers.
Yeah. Welcome everybody. Good evening. And to Dr. Rafique sir and Dr. Deshmukh, perhaps it's good morning. I would first introduce Dr. Abhishek Deshmukh. He's a cardiac electrophysiologist and an outcomes researcher. Dr. Deshmukh passed his MBBS from Maharashtra back in Maharashtra University of Health Sciences. He died in 2005. In 2010, he completed his residency in internal medicine from Medical College of Wisconsin. And later in 2014, he completed his fellowship in cardiovascular medicine. 2016, his fellowship in clinical cardiac electrophysiology from Mayo Clinic College of Medicine. Dr. Deshmukh has an active research where he uses large database to examine quality, outcomes, and risk prediction for heart rhythm disorders. He performs different invasive procedures as expected of an electrophysiologist, but most important, he loves teaching, and he's very much involved in fellows education. So at present, Dr. Deshmukh is co-program director for electrophysiology fellowship program at the Mayo Clinic. He has been voted as the teacher of the year many times, and he has been awarded many times from different sources. So our audience are expecting quite a good lecture from him. Now, our dear Dr. Rafique Ahmed sir. He was born at Mymensingh in 1955. His father was a teacher in the Rajshahi Medical College, teacher of pathology. He passed from there in 1978 as the top student of his class with honors in 5 subjects. He went to Japan in 1982, trained in cardiology and electrophysiology at Nagasaki University Hospital, got the PhD in there in 1988, then went to UK and worked as registrar in cardiology at Westminster Hospital in London between 88 to 99. Then he moved back to USA and trained at University of California School of Medicine and Massachusetts General Hospital of Harvard Medical School. He is board certified in internal medicine, cardiology, and cardiac electrophysiology. He was Associate Professor of Medicine and Director of Cardiac Electrophysiology at Medical College of Georgia, Augusta, Georgia in 1995. He relocated to Baltimore in 2001, and at present he is working as consultant cardiac electrophysiologist at MedStar Heart and Vascular Institute at Washington Hospital Center. His work involves providing full range of electrophysiology services. His wife is also Dr. Shilpi Ahmed, is also a cardiologist. He has one son, Ryan, one daughter, Samia. They are quite established. For the last 15 years, Dr. Rafique has dedicated his full interest for the development of a world-class cardiac electrophysiology service in his native country, Bangladesh. He is the founder of cardiac electrophysiology service of this country. He also established SELS training program at Bangladesh College of Physicians Surgeons in collaboration with the American Heart Association. But perhaps the most important thing is, again, Dr. Rafique Ahmed is a true teacher, a true guru. Ladies and gentlemen, you will find out why we call them guru when they start speaking. Devasrito, you can now go ahead with the next program.
Yeah, so I would request Dr. Professor Deshmukh to take over and start the session. And we have break the session into 2 parts. So with over to you, Dr. Deshmukh. I am quickly unmuting you. Yeah, Dr. Deshmukh, please.
Perfect. Good evening, everybody. I hope you can hear me and see me, and I hope all of you are doing well and healthy with all our current challenging times. So I was asked to talk about bradyarrhythmia, and the topic I thought was interesting that it was called as tricks and traps. So hopefully, my aim to as we go through this talk is to go over some of the tricks to identify different bradycardia and bradyarrhythmias and to sort out how not to fall in a trap so that you can help the patient when you're seeing the patients. I'll appreciate if somebody can mute their screen. I can hear some background, and then we'll keep going.
Tarek,
I,
mute everybody except Dr. Deshmukh.
Perfect. And I'll keep it interactive. So if you want to answer that question, feel free to unmute and answer that question, and we'll keep going. So our learning objective today is to have a systematic approach to slow heart rates on ECG, and further use ECG as a clinical and a tool so that it can help us for pathological correlation. So when we look at any bradycardia ECG, the first thing we need to know whether is it truly bradycardic, is the bradycardia physiological or is it pathological? Is it really dangerous for that patient? Now, is that bradycardia because of failure of impulse generation, meaning that the impulse is not starting in the conduction system? Or is it failure of impulse propagation, meaning the conduction has started, but there is some roadblock somewhere? What is the underlying pathology, and can the ECG give us some hint of what the underlying pathology is going to be? And finally, we are going to talk about what are the other clues on the ECG which can help you which can help you to figure out what might be going on with the patient. Now we all know that the normal conduction in the heart starts in the SA node.
Dr. Deshmukh, can you increase the volume? Audience are asking for it. Increase the volume, please.
Hang on. Can you hear me better now?
We have more than 200 audience already.
Can you hear me now?
Yeah.
Yes, a bit louder would be helpful. Yes,
Is it better now or not yet?
it's better, sir.
Okay, perfect. Perfect. Okay. Sorry about that. So the normal conduction system in the heart starts in the SA node, then it goes to the center of the heart AB node, bundle branch block, and then divides into the right and the left bundle. So as the ECG is going to give us a P and a QRS to know atrial activation and ventricular activation, we can also certainly measure it in the heart, looking at the atrial activation, the ventricular activation, and finally what activation happens in the His bundle. Now I'll start off with a case, and so why is this rhythm slow? Is this sinus bradycardia? Is this AV block? Is it beta blocker overdose? Or is it a pseudo sinus bradycardia? Maybe we can look at it for 10 seconds. And if anyone wants to unmute, you can say the answer, or you can put it in the chat box, and maybe Deb can tell us what the answer is. And then maybe I'll go over some of this explanation.
Yeah, we'll wait for the chat box and I'll update you.
Yes. So why is this rhythm slow? So the patient came into the hospital and was doing okay, maybe was going to get some sort of surgery or colonoscopy or something, and then they found him to be bradycardic. So is it sinus bradycardia? Is it AV block, beta blocker overdose, or pseudo sinus bradycardia?
So Dr. Abhishek, I will count another 10 seconds to finalize the panelist. What they are finalized from the audience. So what we have predominantly got the answer number 1. Couple of people have answered 4, and some of them have answered 2. So we have a mix and match.
That's wonderful. That's what I wanted to know. Then we'll keep going from now. Perfect.
Yeah.
So this turns out to be pseudo sinus bradycardia. And why it is, we'll go over the approach, because it is very, very important to analyze this. So this comes up a lot when we are looking at, say, non-conducted PACs, which causes a pause, or you have blocked PACs, which may give an appearance of 2-to-1 AV block, but actually it is not 2-to-1 AV block. It is just atrial bigeminy, which is going on, which causes bradycardia. In order to understand this, first of all, we need to understand how the heart is placed and how the ECG leads are placed in the heart. So we all know in the right lateral view of the heart, your SVC, you have your SVC here, IVC here, your SA node is set up somewhere here. And when the impulse comes from the SA node, it depolarizes the atrium, and then all the leads in the 12 leads in the heart where it is located, it's going to pick up that activation. Now, one principle to know in vector electrocardiology is that wherever there is an electrode, if the activation is going towards that electrode, it makes a positive wave. And whenever the activation is going away from that electrode, it makes a negative wave. So activation going towards the electrode, positive wave, activating going away from the electrode, negative wave. So this is our lead V1. So if we open up our chest and if you look at where actually what is underneath lead V1, it turns out it is the part of the right ventricular outflow tract. So our sinus node is here. And if we have activation, which is going towards V1, we get an initial positive wave, and then it goes back towards the left atrium to depolarize the left atrium, and that causes the negative component of the P wave. So in lead V1, this is, you see, the initial positive and later negative. Same thing, your lead 2, if you remember the vector diagram, is located somewhere here. So if the activation is happening from somewhere superior, as the activation is going towards lead 2, you get a positive lead 2. This is sinus rhythm evaluation of the ECG. Now, once we know this, the next step to really understand is that how is the atrium getting depolarized. So the way atrium gets depolarized from the sinus node somewhere here, the way left atrium gets depolarized majority of the time is through this Bachmann's bundle. Next is the fossa ovalis. And finally, some component is coming from the coronary sinus. So the majority pattern is coming from the Bachmann's bundle. And that's the reason why where you have lead V1 here and your sinus node is firing from here, the initial activation becomes positive, but the dominant activation to activate the left of the rest of the left atrium makes a negative wave. And that's why you get a positive and a negative wave. So whenever you don't see this positive and a negative wave in V1, or you see completely positive wave or completely negative wave in V1, then you need to start thinking that this is not a sinus beat, and this might be something else. So what something else it is going to be? It can certainly be, it can be an ectopic rhythm. It can be a PAC. So if you have a PAC coming from somewhere in the low right atrium, your V1 is going to look different. Your inferior lead, lead 2, lead AVF is going to be more negative because those are inferior leads. If you have a PAC coming from the left atrium, so your V1 is somewhere here. So all the activation is going towards V1. So that is going to make you a more positive V1 in a more positive P wave in lead V1. So when you're analyzing some of these EKGs, it is very important to know that if you see a PAC, whether it is truly a PAC, because you can have blocked PAC or you can have PAC, recurrent PACs which may still conduct, but it may give a pattern of group beating and Venky Back. But the clue is going to look at the P wave. If the P wave is different, it is PAC. Now, how different the P wave is really depends on where these P waves are coming from. So normally you get a P wave, QRS, T wave. If the P wave falls somewhere here, you're going to see it. But if the PAC falls somewhere here, you really can't see the P wave. But what you can really see is the T wave. So the T wave, instead of being nice and round like this, may become more pointed. Whenever you get a more pointed P wave, a more pointed T wave, which is different than the T wave what you had seen, then think that there might be a P wave which is hidden there. So this is how a PAC will look like. So in that particular example, what we saw, the patient was actually having a run of atrial bigeminy, and the PAC is present here and it is getting blocked, doesn't conduct, but it may give a false appearance that you're having a 2-to-1 AV block, and you may offer a pacemaker, but actually the pacemaker is really not going to help here. And all you need to is to treat the PAC or wait for a while and see if the PAC responds and see how things go. So this is how the T wave is going to be different compared to this T wave. Now going back to our ECG, so this was the P wave, this was the P wave, but you see there is something here which is very, very different. And that's the reason why this was kind of a pseudo sinus bradycardia and not like a true sinus bradycardia, because of all the PACs which we just saw. So is this concept clear, or do anybody have any questions before we go to the next step? Great. Again, if you have any questions, feel free to put it in the chat box, and Dept will tell us what we can discuss.
So far, we haven't got any question regarding it. You can proceed.
Wonderful. That means either they are understanding everything or they are not understanding anything, but we'll keep going. Okay. So next, we'll talk about this other situation which happens very frequently. So 84-year-old gentleman, and he's having syncope. So what could be the reason for the syncope? Now again, I'll walk through the ECG. You have a P wave here, P wave here, P wave here, no P wave here, kind of a pause here, no P wave here as well, and maybe a P wave here. And then you will tell me, well, doc, you just said that there might be a PAC, but this T wave, this T wave, this T wave all look the same. So there is not a PAC going on, but for some reason here, there is no firing of the P wave. So what this could be? So no P wave, and then finally you have a junctional escape. So this brings up to the next point of what is basically sinus node or sinus node exit block. Sinus node exit block is failure of impulse generation, which is happening from the sinus node. So you may have a block, and then you have to sort out whether the block is at the level of the sinus node or at the level of the AV node. Now, how can we show that? Well, the easiest thing is to look whether before a block, whether you had any P wave. If there is no P wave, that means no P wave has been generated from the sinus node. So that is more likely to be consistent with an SA exit block. Now, where it gets confusing is that you may have a pattern like this, kind of a group beating pattern, and we are trying to magnify it as much as possible to see whether we can see a P wave, and we can't see a P wave. So maybe there is actually no P wave. Then how to figure those things out? Well, you can certainly have an SA exit block, and when you have group beating going on, then without a P wave, then start to think whether you're dealing with an SA exit block. An SA exit block again have two kinds, Mobitz 1 and Mobitz 2. In Mobitz 1, there is no P wave in the pause. So for example, here, there is group beating going on and there is no blocked PAC because the T wave all look the same. For Mobitz 2 sinus node exit block, the pause what you get is twice the PP interval. So if the pause what you get is twice the PP interval, then start thinking that this might be like Mobitz 2 block. And again, if patient is symptomatic, may warrant pacemaker. Now, where this Mobitz type 1 becomes confusing is sinus arrhythmia sometimes. The RR interval keeps on changing, PP interval keeps on changing. But again, sinus arrhythmia would be more respiratory related. Mobitz 1 SA exit block generally is not respiratory related, and you will have a fixed pattern which is going on. So again, group beating, but no P wave and no P wave on the T wave, think you may have Mobitz 1, think you may have SA exit block. And then if you have SA exit block, to find out whether it is type 1 or type 2, look at the block. If the block is exactly twice the PP interval, that is Mobitz 2. If the block is not twice the PP interval, that's Mobitz 1. This is how sinus arrest is going to look like. So somebody is having sinus rhythm, nicely chugging along, and boom, suddenly becomes bradycardic, and then there is no P wave happening. And this is an example of sinus arrest. This is an again common thing what we see in some of our older patients. Say somebody has atrial fibrillation, we are treating them medically with say beta blockers, diltiazem, calcium channel blockers, and they complain of recurrent syncope. And we are not able to find out. Sometimes they don't wear the Holter monitor, sometimes we don't have access to long-term monitors. For example, if you catch it on an ECG or a telemetry, what happens here is that you have AFib going on, and then suddenly there is a long pause followed by a junctional beat, and then sinus starts again. So why this happens sometimes is, again, it's interesting to know how this thing works. So for example, you have your SA node here, which is firing. The heart has 4 chambers. SA node, which is going to generate your sinus P wave. But when you're having AFib, everything in the atrium is going on at a very chaotic rate, at a very fast rate. You can even see how fast this is going on here. So this kind of suppresses this sinus node for a long time. For whatever reason, say cardioversion, or the patient spontaneously converts back into normal rhythm, because this sinus node is suppressed for such a long time, the sinus node takes forever to recover, and that results in this long pause, and that may make patients pass out or have syncope. So this is an example of tachybrady syndrome in AFib. AFib stops, patient instead of feeling better actually feels worse because there is sinus node dysfunction, long pause, and a concern for syncope. So this is an example of tachybrady syndrome. The next thing, and I think there are some comments and questions, we'll come to that, or we'll, if there's something burning, Deb, you can interrupt me.
Yeah,
Now,
there is a question couple of times by Dr. Khurshid Alam that
okay.
how can they differentiate SA exit block Mobitz type 1 from AF?
From AF?
Yeah.
Okay, so that's a good question. So what happens in SA exit block, the problem is in the SA node. So you may still see the P waves, what we are seeing here. You will still see the P waves which are happening here. So in AFib, you will not see any P waves. So as long as you're seeing the P waves with a group beating pattern, then you cannot get P waves in an AFib ECG. Is that okay?
Great, sir.
Yes, sir.
We'll keep going. And again, if you have anything we want to go slowly, I can do that. Next, this thing happens also quite frequently. So patient is in the hospital and he's there for a completely unrelated reason, may have pneumonia or fever or COVID or whatever. And then at night, the resident doctor sees this, that there is a long pause. So how to evaluate these long pauses, what you see on telemetry? So is this harmful or is this benign? Just as if people can comment on this, is this a good pause or a bad pause?
Okay, we'll wait for another 10 seconds to respond. So participants and anyone can respond in the chat box for maybe in 10 seconds. So I start countdown.
So are you going to call Professor Atahar Ali to put in a pacemaker or to see the patient right away? Or you are going to say, well, you know, maybe the patient is sleeping, I'll go back to sleep and not worry about anything.
So there are a couple of answers. I will respond to you before after Dr. Atahar Ali, Professor Atahar Ali respond. So Professor Atahar. So if you can unmute, sir, please. Yeah.
Sir, this ECG, that is it during the night time, that is sleep time?
That's a very, very good point. So first thing, when somebody shows you a tracing, make sure, look at all the information. So this was done at 11:27 p.m.
Right, sir.
So sleep time, probably.
Sleep time, sir, probably. Sir,
Probably.
it is during the sleep time, sir, it is due to the increased vagal tone that causes the long pause.
Exactly, very astutely picked up that maybe this is increased vagal tone. But how to sort that out? The way you can sort that out, especially for our students and residents and who are new to this field, is that look at the PP interval and then look at the pause. If before a long pause, you are not seeing, there is no P wave here at all. Do you agree? So there is no P wave anywhere here. But before you get that block, you have a long P to P interval compared to here. And then when you have a block, there is no P wave which starts the block. So you basically have, again, sinus arrest, or the sinus node just goes to sleep because there is no P wave which can set this thing off. Now, sinus node is innervated, as Dr. Atahar Ali pointed out, by parasympathetic and sympathetic nerves. At night, generally when we are sleeping, the parasympathetic tone is high and the sympathetic tone is low. And then when it is too low, the sympathetic tone or the parasympathetic tone is too high, then patients can certainly have bradycardia, can certainly have asystole, but it normally gets better. Now, the typical situations where you would see this is kind of obese patients, patients who have untreated sleep apnea. They are going to have slightly higher vagal tone when they are sleeping, and they may be at the risk of even having sudden cardiac death at night when you have such long pauses. So something to think about. And most of the time, these causes are reversible, and control of sleep apnea or something like that may help to prevent some of these pauses. Good. Now, lastly, we will talk a little bit about bradycardia.
Dr. Deshmukh, can I make a comment?
Yes, sir.
Please.
So I want to re-emphasize about this, what Dr. Deshmukh, this is a very important ECG. And we get called frequently in patients who have no symptom. Even if this happens during daytime, you have to go and find out if the patient is sleeping or not, because a lot of times patients lying in bed are sleeping. And there is this reflex, we get called that, oh, put a pacemaker in. So please be careful about it. This ECG is very, very important. Thank you. It's a wonderful lecture going on.
Thank you, sir. Thank you. All right. So we'll keep going.
Yeah.
So I know my topic was bradycardia, but one more bradycardia situation you have to be very, very careful is that sometimes bradycardias can set off tachycardias, and those tachycardias can be really bad, and they can have polymorphic ventricular tachycardia that can go into VF and patients can die. So how to identify those? Now, if I tell you this, then all of us will get very, very anxious that maybe, you know, everybody who has sinus bradycardia may be at a risk of dying suddenly. It's not that true, but then the way to assess that is to look at an ECG and then try to see if the patient is having these something called a short, long, short sequence. So you have a QRS, then you may get a PVC. So this timing is very short. So
can you use the annotation, because a lot of people are seeing from mobile as well? That
yes,
will be
I'm using annotation. Can you see it?
Yeah, now it is perfectly fine.
So you have this short form. This is short coupling interval. Then you get this long coupling interval, and then you get this short coupling interval. So if you have a sequence, somebody is saying sinus bradycardia, but is having some PVCs, and this causes something like this short and long, and then followed by short sequence, that can actually initiate some non-sustained VT, polymorphic VT, which can degenerate into VF, and patients can die. So not all patients who have this cannot have this. You don't need a defibrillator or something else to treat this arrhythmia. You actually don't even need beta blocker to treat this arrhythmia, because the problem why this is happening is actually bradycardia. So in these cases, what you need to do is avoid the offending agent. So if they're too bradycardic because of heart failure medications, beta blockers, verapamil, then stop those medications. Make sure there are not ischemia. This is again kind of exacerbated if somebody is in today's time, you know, specifically on hydroxychloroquine, azithromycin, QT gets prolonged, they are baseline bradycardic, little bit of PVCs, they can have this short, long, short sequence and go into torsades. So something to think about, that if you have bradycardia, the problem is not only asystole or complete heart block, the problem can still be polymorphic VT and VF. And the clue would be to look at this short, long, short sequence, and that is going to tell us whether this patient is at a risk. Now, will everybody have this? Probably not, but a lot of people will have this. So how to prevent it, say overnight, if you're on call or if you're seeing a patient and all that, is just increase the heart rate. So you can give dopamine, you can give isoprenaline, you can, if you have access, you can even pace their heart a little bit faster and then prevent this long pause what you're having in the middle. So once that is prevented, this short, long, short sequence is avoided and you will not have induction of this polymorphic VTVF. Now, some of the other causes could be ischemia. This is commonly seen during ischemia, commonly seen with hypokalemia, hypomagnesemia, other electrolyte issues, long QT syndrome, and medications which cause prolonged QT interval. So very important concept to think about, that bradycardia, the only problem with bradycardia is not having complete heart block or asystole, but they can also initiate polymorphic VT and VF. This probably will be the last slide I will show in the sinus node variety before we go to the AV blocks. So I'll clear this and maybe we can do a little bit of an audience poll here again. So 70-year-old female presented with bradycardia. So the question for everybody is, whom are you going to call? Are you going to call ICU doctor? Are you going to call cardiologist? Are you going to call cardiac surgeon? Are you going to call nephrologist?
So
are you going to call endocrinologist?
So we have a poll launching quickly. So there are 4 options in the poll for the audience. Number 1 is cardiologist. Can you, Dr.
Yes,
Abhishek, can you
number
comment?
1 is cardiologist. Number 2, cardiac surgeon. Number 3, intensivist. Number 4, nephrologist.
Perfect. So we have these 4 options. So I'm launching the poll quickly. Yeah. So poll launched. We are waiting for the answers. So as soon as I get the answer, I will update you.
Yeah, and as people are thinking, I'll just walk through the ECG. Again, you can see bradycardia, but we are not seeing a lot of P waves. So maybe, you know, I talked about, is it SA exit block or not? Hard to know because there is no pattern here. Clearly no P wave. So in bradycardia, we also have to look beyond the P wave and the QRS. There are other things on the ECG, such as T waves and other things what we can see. So bradycardia.
Yeah, I will give another 10 seconds to our audience. We have got almost more than 34% voting done. So
wonderful.
Maybe another 10 seconds, I'll close the poll and I'll tell the result to you.
Good. So bradycardia, then maybe there's a little bit of low voltage complex. If you look at lead 1, 2, 3, AVR, AVL, AVF. So what could be going on in this patient? So whom are you going to call first?
Okay. So I conclude the poll quickly. And the answer came number 1, which you have said, 42% of the answers are for number A, 39% of answer goes for number D, and then number B came at the last 4% and number C came 14%. So the answer from the audience is A, D, then C, then B.
Okay. So I think all of you said call the cardiologist, which is good because I think all of you are interested in cardiology. But mind well, not all the causes of bradycardia can be treated by cardiologists. And that's why I also suggested endocrinologist or nephrologist or neurosurgeon or anybody else. So there are a lot of causes which happen outside the heart which can actually cause bradycardia. This is one of them. So this, if you look at the ECG like we were going through, so there is no P wave, but look at the T wave. The T wave are quite impressive. So tall T waves, Himalayan T waves, tall T waves. So we start to think of hyperkalemia.
Yeah, we got a couple of answers in chat box, that hyperkalemia and ICU specialist. That
wonderful, wonderful, wonderful. So this patient very nicely picked up by a lot of you. So low voltage complex, generally dialysis patients will have pericardial effusion. They may have low voltage complex, but the T wave being this prominent is suggestive of hyperkalemia. So this was, potassium was about 7 at this point. After dialysis, the P waves are back, the T waves go down, and no cardiologist ever saw this patient, no cardiac surgeon saw this patient. So dialyzing this patient is going to save his life, and that's going to, you know, make sure this bradycardia goes better. So just a couple of things on hyperkalemia. So you, like we pointed out, you get tall T waves. At that time, the potassium level is say between 5 and between 5.5 and 6.5. But as the potassium level actually goes up, so between 6.5 and 7.5, you actually lose the P wave. So that's very important to know that in hyperkalemia, you can lose P wave. So it's also called, as you may remember, sine P wave, so loss of P wave. So you lose actually P wave. And then as the hyperkalemia becomes more and more severe, you have already lost the P wave, then the QRS becomes wide, and then you have ventricular arrhythmia, asystole, VF, and all that. So one of the markers of hyperkalemia, although is tall T wave, but if you lose the P wave, you really have to look for a nephrologist and see how we can, or an intensivist, and see how we can dialyze this patient as soon as possible. Something important to think about. So again, when you are approaching ECGs of bradycardia, and I'm not talking about AV blocks, I'm just talking about bradycardia at the level of sinus node, you know, there are a lot of causes which can cause it, but also think of causes outside the heart: hypothyroidism, amyloidosis, raised intracranial pressure, hyperkalemia. A lot of these things can cause sinus bradycardia or junctional bradycardia. So something to think about. So moving on. Yes,
so one of the junior fellow, who is from MMCH, he gave the correct answer within 4 seconds. Dr. Rehan.
Dr. Atahar Ali is going to give him a big present at the end of this meeting.
Yeah.
Okay. All right. So moving on, we'll change gears and talk a little bit about AV blocks. So we have a 45-year-old college professor, very, very fit, and he has an Apple Watch and he has a Fitbit, and he watches his heart rates every time. And he may be one of you, and you know, he gets called to this ECG meeting, and then while giving this talk, he suddenly became syncopal and started having shortness of breath. So young man, so highlight is young man, shortness of breath near syncope, and this was the ECG. Okay, and then the question is, what does the ECG show? I'll go back on the ECG again. 2-to-1 AV block, Mobitz 1, Mobitz 2, complete heart block, or sinus bradycardia. So 2-to-1 AV block, Mobitz 1, Mobitz 2, complete heart block, sinus bradycardia.
So again, we launched the poll, and 1, 2, 3, 4 is the choices. So if you can go to the previous slide, maybe after 10 seconds, so people can see the answer sequence.
Okay. So this is the sequence: 2-to-1 AV block, type 1, type 2, complete heart block, sinus bradycardia. I wish I could show you both slides at the same time, but this is our main ECG. Yeah. So as you people are polling, I'll go over this ECG. So you have sinus P wave, QRS, P wave, P wave, QRS, P wave, P wave, QRS. Now already you know that we have more P waves and then less QRSs. Once that happens, you need to understand whether the P waves and the QRSs are related to each other. So all the R to R intervals are almost the same. So keep that in mind. Now P to P interval are also kind of very, very similar. So that's important to know. So the P's are going at its own rate, the R's are going at its own rate. Now are they related to each other? So the way to find that out would be to look at the PR interval. The PR interval is here, PR interval is here, PR interval is way short here, it's way long here. It keeps on changing, very, very variable. So that tells us that the atrium is going at its own rate, the ventricle is going at its own rate, and so this is kind of an AV dissociation. So let's see what people polled as.
Yeah, so I'm producing the result. So maximum people have voted, almost 50% people have voted
complete heart block.
Complete D. And I can see from the chat box, there is some people has written the suprahisian CHV as well.
Suprahisian block level, okay, we'll come to that. Yeah. Good. So whenever you see a ECG of complete heart block, you know, that's great. You have diagnosed complete heart block. But remember, you know, we are also physicians trying to treat the patient. So once you see complete heart block, also try to see what else do you see on the ECG. Are you seeing ischemia? Are you seeing prior infarct? Are you seeing hyperkalemia? Are you seeing anything funny? So here you can see there is some notching, which is some notching in the QRS in lead 2, 3, AVF, AVL, lead 1. So it tells you that whenever you have notching, normally when you get a nice QRS, that is because the activation is going nice and steady without any interruption. But if there is a lot of scar or slow conduction, as the activation is going through here, that's the reason why you get some notched QRSs. So what you can see somewhere here, what you can see somewhere here. So whenever you see notching of QRS, start to think that there is some sort of slowing of conduction happening there, and that may suggest some scar or abnormal substrate in that location. So based on this complete heart block, you already know that the patient will need a pacemaker, and we'll talk about the level of block. But you also know, looking at this, that the ventricle may not be completely normal with all this fractionated QRS and all this notching, what you are seeing here. So I completely agree with everybody that the patient has complete heart block, and the patient got a pacemaker. Now remember, I told you this patient is a 45-year-old college professor. So whenever somebody is young or middle-aged, then you have to really think about why this patient is having complete heart block. Now, some of the things are degenerative, infectious causes, rheumatic, autoimmune disease, infiltrative disease. Sarcoidosis comes up very commonly, at least in America and this part of the world. Sarcoidosis and TB comes up a lot in India and Southeast Asia and Bangladesh. Neuromuscular disorders. So a lot of things actually can cause complete heart block in a young patient. Now remember, again, we looked at those QRSs, and those QRSs look quite abnormal. So that means we have to do something more to find out why this QRS is so abnormal. So patient undergoes a dual chamber pacemaker, which was probably the right thing to do. But there is actually a guideline that you have to screen for sarcoid if there is complete heart block or high degree AV block in patients who are younger than 60 years of age. And if the screening is suggestive, then the patient should even get a biopsy. And this, again, for your own reference, how this whole algorithm works, and hopefully you can access it. But what we did in this patient, that the patient underwent PET scan, and then some of these lymph nodes lit up. And whenever you have that, then start thinking, at least in this part of, start thinking that there might be sarcoidosis. Biopsy was done of one of the lymph nodes, non-caseating granuloma. So what's the next step? Upgrade to ICD, upgrade to BIV-ICD, immunosuppression, nothing to do. So let's have a quick poll on this.
I quickly launching the polling. Yeah, so I have launched the polling and people have started responding.
And again, the reason I'm showing you this ECG, because, even when somebody has complete heart block, we put in the pacemaker. It's not that we should discharge the patient and stop thinking about them. We still have to keep on thinking about them and see why this patient had complete heart block, and, try our best to see what we can do. Because you can put in a pacemaker, but the patient may still have a bad outcome depending on the underlying pathology. So I'll keep going. Any initial trends?
Yeah, there's a maximum almost 76% of the patient, 76% of the attendants are going voted for this C. And if it goes right, then there is a person who have written around 2 or 3 seconds answer. He has given something. I'll tell you once answer is ready. So we have stopped the poll.
But if that person's answer is wrong, he's taking us out for dinner after this, or lunch for me. Okay.
Yeah, sure.
So when we look at approach of sarcoidosis or TB, I won't go through the whole algorithm, but basically if they have complete heart block, they are at a risk of having VT. So if the EF is even normal and you have a pacing indication, we have to give them an ICD. The reason for that is that if you have complete heart block and sarcoid, you give them a pacemaker and then you start immunosuppression, they are actually, it becomes pro-arrhythmic. And within the first 1 to 6 months, there is more chance of having VT-VF. So that's why in patients with sarcoidosis who have complete heart block or high degree AV block, when the suspicion is very high, instead of a pacemaker, we have to give them an ICD. So we actually got the patient back again, changed his pacemaker to an ICD once the diagnosis was made. So again, the point in case that we have to keep on thinking about patients, unusual patients when they have complete heart block, especially at young age. So now let's look at the patterns of block. So we all know prolonged PR interval causes first degree heart block, delay. Then there is second degree heart block, Mobitz 1 or Venky Back, Mobitz 2, 2 to 1 AV block, advanced block or high degree AV block, complete heart block. And then in the end, I'll talk about some funny patterns on the blocks. So before we talk about first degree AV block, we need to know a little bit about why we get a PR interval. Can you see my whiteboard?
Yeah, it's not yet coming, but yes, now it is okay.
Okay.
We can.
So you get a P wave and then you get a QRS and then you get a T wave. And then what we are talking about is this PR interval. And with that, if that gets delayed, then you get a first degree AV block. Now, in order to understand what is a PR interval, you have to understand again how the activation goes in the heart. So it starts in the sinus node, goes to the AV node, bundle of His, and then the right and the left side. Now let's focus on the AV node. Now what happens in the AV node is the activation is coming and the AV node has a slow pathway and a fast pathway. Slow pathway and a fast pathway, and then bundle of His, and then divides to go on to the right and the left side. So if you have to go, say, from Dhaka to Chittagong, you are going to take National Highway 1 so that you can zip through all the traffic and not stop anywhere. And that's what happens in a normal heart. The conduction goes over the fast pathway, and because that's the path of the least resistance. Now, as the conduction is going the fast pathway, it is like a wave. So although the majority of the wave goes down, some part goes up into the slow pathway. And that's a term called as retrograde concealment. So the activation goes from the sinus node to the fast pathway, goes to the His and goes to the right and left side, but some part goes into the slow pathway. So that's why at baseline, normal patients have a nice normal looking PR interval. As patients get older and older, this fast pathway starts to become weaker and weaker. And at point the fast pathway blocks, the activation can go down the slow pathway and they can have a longer PR interval. So this PR interval really depends on how the conduction is going on the AV node. And all of a normal rhythm, you have conduction goes down the fast pathway, conceals up into the slow pathway. We don't see this pattern in normal ECG because by that time the ventricle has already depolarized and you get a normal looking PR interval. So any disease in the AV node, the PR interval starts to get longer and longer. So very important thing to know this, because this is going to help us figure out some of our AV blocks. So this is first degree AV block. This is second degree type 1 AV block or Venky Back. So again, I'll walk through this, that you have PR which is shorter, PR becomes longer, even more longer, and finally it blocks here, and the return PR is very short. So this is classic Venky Back or Mobitz type 1. Then you have a second degree type 2 AV block. So again, a group beating pattern. So we looked at SA exit block type 2, that was also group beating pattern. But again, this is different than SA exit block because you clearly see a P wave before the thing blocks. So if you see a P wave, that means the P wave has already happened. That means the atrium has already depolarized. That means it has to come either from a SA node or it may be a PAC, but all these P waves look the same. So that's why it is sinus rhythm. So group beating you would see in AV block second degree type 2 AV block. But again, this is going to be different from SA exit block because you don't see a QRS, but you still see a P wave. So the block is at the level of the AV node. Now what happens here in Venky Back is the key thing to really know that the standard concept is look at PR interval, it gets longer and longer and longer and blocks. That's perfectly fine, but make sure that the P to P interval is always the same. That's important to know. the PR will keep on getting longer. But as the PR gets longer, actually the R to R interval starts to get shorter before it blocks. And then once it blocks, the return PR is much shorter, and then this whole phenomenon keeps on repeating again. That's why it is called as Venky Back periodicity. So P to P remains the same, PR gets longer and longer. Actually, the R to R interval becomes shorter and shorter before it blocks. And when it blocks, the time interval between the two block beats is actually less than the time interval of the two QRSs. So again, very similar to what concept we heard in SA exit type 1 block, that the block interval is less than twice of the R to R interval. Now compare this with a second degree AV block. You will have P wave, PR interval QRS, P wave, PR interval QRS, P wave, no QRS, P wave, PR interval QRS. So the PR interval remains the same. The P to P interval remains the same. The R to R interval remains the same. You get a block, so there is no QRS, but that interval is exactly twice the interval of the preceding two QRSs. So this is how you would differentiate a type 2 from a type 1 AV block, is to look at the PR segment, PR segment being not changing. Think of type 2 block. In type 2 block, group beating, differential diagnosis of group beating could also be SA exit block. Everything is going to be very, very similar, but in AV block, you're going to have a P wave without a QRS. In SA exit block, you will not see a P wave, hence no QRS. So just a quick trick about how to sort these things out. This is an example of 2 to 1 AV block. And again, a common question which gets asked all the time during rounds is that, we talk about marching this P to P interval, but why this P to P interval is longer than this P to P interval? So the P to P interval where there is no QRS is slightly longer compared to the P to P interval which has the QRS. And the reason for that is a phenomenon called as ventriculophasic activation. And that results in, so if there is no QRS, the carotid, so there is no QRS, so there is some ischemia, there is no ventricular contraction. So the carotid bodies get ischemia, they send out a sympathetic drive, and that's why the next P to P interval becomes shorter. Again, you have AV block, the same thing repeats again. So in 2 to 1 AV block, the P to P interval will be longer in patients where there is dropped QRS, and that is physiological, that is called as ventriculophasic respiration. So we'll keep going. This is high degree AV block, so more P waves compared to QRSs. So again, high degree AV block and complete heart block, what we talked about. Now there was a question about how to differentiate the level of block. So there are, the best way probably is going to do an invasive EP study, but a lot of times clinically you will be able to sort out whether it is a block at the level of the AV node versus block at the level of the infrahisian block. So clues, QRS will be narrow when you have a block at the level of AV node compared to an infrahisian block. And why is that? Again, if you see, you have the reason why we get a narrow, and again, if I'm going overboard, you can feel free to stop me, but I think some of these concepts are very important. So you have SA node goes down to the AV node, his bundle, right bundle, left bundle. The reason our QRS looks the way it looks normal is because the predominant activation is going down the right and the left bundle. That explains why the QRS looks why the way it looks like, because of good synchronized activation of the ventricle over the bundle branches. If there is a bundle branch block, so left bundle, it looks wide. If there is a right bundle branch block, it looks wide again in lead V1. But if it is narrow, then that's your clue that the block has happened either at the level of the his or above the his, which is the AV node in a normal QRS. So then the question becomes how to know whether it is truly at the level of AV node versus at the level of the his. So for that, you have to do few things. So number one, look at the PR interval. If the PR interval is getting longer and longer, block is at the level of AV node. For block at the level of his intrahisian block, the PR will be normally stable. Second, which we don't suggest to do, is try to do a carotid sinus massage. If you have block at the level of AV node, carotid sinus massage is going to make it worse. Infrahacian block may improve. But if the block gets worse, think that this is going to be a block at the level of AV node. Same thing with atropine. If you give atropine and the block is at the level of AV node, then the conduction is going to improve, but it's actually going to get worse when you have block at the level of infrahacian block. Same thing with exercise. So this would be clinically how you would be able to differentiate level of block at the level of AV node and at the level of His. Infrahacian is simple because the QRS is going to be wide, but at the level of His and AV node, quick trick would be atropine. Other thing would be carotid massage. Third simpler thing is going to be just walk the patient and hold the patient and walk him. Heart rate increases, block gets better, maybe block at the AV node, block gets worse, infrahacian block. So let's look at this. Is it a Mobitz type 1 block or what is this? Again, I won't do a poll here, but again, this happened during night. So before it blocks, here, so there is a P wave here before it blocks. So the block happened at the level of AV node, but before it blocks, the P to P also prolongs. So again, as Dr. Atahar Ali had said, that when it happens during sleep, you know, the P to P will get prolonged and then you may get a block. So again, this is a combination of high vagal tone on SA node, high vagal tone on AV node, and that's how this thing blocked. Again, really nothing to do and just wait and watch. Next, I thought we'll talk very, very important is about complete heart blocks in setting of acute MI. Now, let's see this ECG. What's going on here? 65-year-old male with chest pain, inferior wall MI. We can clearly see inferior wall MI, which is happening based on the ST elevation 2-3 AVF and the usual pattern. But also see there is probably no P wave here. So maybe this is a P wave, hard to know, or this could be just an isolated firing. You know, I think Dr. Rafique would enjoy this differential diagnosis of this isolated firing here. But generally, there is no P wave and in setting of acute ischemia. So let's figure that out about how to analyze these things. Very, very important concept. So you get an SA node, then you have an AV node, bundle of His, right bundle, left bundle. Blood supply of the right of the SA node comes predominantly from the right coronary artery. And say if this is the LAO view and the right coronary artery is going this way, the branch which goes northwards is the branch to the SA node artery. So if you have a very proximal RCA infarct or a thrombus, then if this artery doesn't get perfused, so SA node does not fire, so then you can have junctional bradycardia or profound sinus bradycardia or sinus arrest because there is no firing happening from the SA node. As you start to get more mid to distal RCA, the RCA branch gives a branch to the posterior descending artery, and one branch called as the posterolateral artery actually goes to the AV node. So the AV node is supplied by the posterolateral branch of the right coronary artery. So if you have an ischemia or an MI in the RCA location, then you are going to have a complete heart block because the AV node gets infarcted. Now the standard teaching is if your AV node gets infarcted in inferior wall MI, indication is not to give a pacemaker because this AV conduction is going to improve over a period of time and you just have to wait and watch. Now let's look at the blood supply. So we looked at sinus node, RCA, AV node, RCA, but coming from this posterolateral branch. Now how about the His bundle? The His bundle is supplied by the first perforator coming from the LAD. The right bundle is supplied by the perforator coming from the LAD, and the left bundle is also supplied from the left anterior descending artery. Now, if the AV node infarcts, the next escape rhythm is going to be happening from the His bundle. So as long as there is no ischemia to the His, the patient will recover conduction and do well. But if you have in very, very proximal LAD infarction, ostial LAD infarction, and this septal gets compromised and the patient gets complete heart block, the His gets infarcted, His only has single blood supply coming from the septal perforator, and the patient needs a pacemaker. LAD, complete LAD infarct, complete heart block are never going to recover, and they need a pacemaker. Next, when you look at ECGs of LAD infarction, proximal LAD infarction, we always know that they cause left bundle branch block, but they also cause right bundle branch block, because again, the early septal perforator supply to the right bundle, and that can get infarcted. So basically, again, as a summary, acute MI and complete heart block, sinus bradycardia, junctional bradycardia, think that the SA node is not getting blood supply, complete heart block with an inferior wall MI, probably mid to distal RCA, the PL gets compromised, so the AV block happens, but this AV conduction is going to improve because the HIS is going to save you, because that perfusion is still preserved from the septal perforator. Coming to the left side, proximal LAD, if the septal perforators are compromised, HIS is infarcted, this is never going to get better, and you will need a pacemaker. Common to see right bundle branch block also with an LAD infarction with the ostial LAD or a proximal LAD, and left bundle branch block we all know is fairly common when you see these EKGs. So going back, so this patient had the junctional bradycardia, what I showed. Proximal RCA was occluded. There is a small branch here, but once this gets reperfused, you'll see a very, very big branch which is going up into the atrium, and that was perfusing the SA node. Patient did well, sinus node conduction improved, and no need for a pacemaker. Now, AV block can also happen in inferior wall MI, not only because of ischemia, because of drug effect like morphine, reperfusion arrhythmias, and something called as basal gyrist reflex, where there is higher vagal tone. This is an example of anterior wall MI and complete heart block. This is never going to get better, and the patient will need a pacemaker here. Now, maybe last ECG I'll show. Is my time coming up?
Yeah,
maybe
almost.
I'll show one last.
Yeah.
Maybe I'll just, this is last ECG I'll show you what's going on here. And again, I won't make an audience poll here, but just something to think about, because this is, again, you see, if you start looking at these things more detailed, you'll start to see this thing. So you will see a P wave with a QRS, no, and then a QRS, and you don't see a P wave. P wave, no QRS. P wave with a QRS, QRS, P wave with a QRS, just a QRS without any P wave. So kind of a funny pattern here. You know, you are getting kind of a group beating. Your AV conduction is little bit variable. And for every P wave, there is actually 2 QRSs. So is this ventricular tachycardia? Unlikely. And again, Dr. Rafique will go over these things. It's a narrow complex tachycardia. QRS looks as good as it can get. So this is not going to be ventricular tachycardia. So what's going on here? So whenever you don't know what's going on, a suggestion I will make is to make a ladder diagram, meaning that you draw a P wave, you draw a QRS and measure these intervals. So for this P wave, there is this QRS. For the next P wave, there is this QRS again going on. So this, for one QRS, there are for one P wave, there are basically 2 QRSs going on. So what's going on here? Now, way to understand this is, again, comes back to our first picture, what I showed you: SA node, AV node, slow pathway, fast pathway, HIS, and then the ventricle. So normally activation is going down the fast pathway, retrograde conceals into the slow pathway, but that we don't see as the HIS gets activated and we get a QRS. Sometimes what can happen, this SA firing can go down the fast pathway, can also go down the slow pathway, because maybe you don't have this retrograde concealment and it is timed in such a way that you get a P wave, you get a QRS, and so that went down the fast pathway. And then this wavefront also reaches and makes another QRS, and then you get a P wave followed by QRS again. So for one P wave, you can get 2 QRSs, and that's called as double firing or 1-for-2 response. Again, if you look at Holters maybe, or if you look at ECGs in young patients, sometimes you might be able to see this unique 1-for-2 pattern. So something, again, important to think about. And this is again happening because of lack of retrograde concealment. So you, for one P wave, you are getting two QRSs because one goes down the fast pathway, one goes down the slow pathway. I wanted to talk about a little bit of pacing ECGs, but maybe I might be getting late for the next talk, so I won't show this. But just as a summary, whenever you assess an ECG with bradycardia, develop a plan. Look at the patient as a whole, look at the P, look at the QRS, but also look at the T waves and everything else what's going on in the ECG. If you don't know what's going on the ECG, develop a ladder diagram. So draw it out for which P wave you're getting, which QRS and all that. See what is blocked, what is not, and what is not blocked or what is conducted. Look for this funny looking T wave. There is almost always going to be a P wave on top of that if there is a blocked PAC which is happening. Look for the P waves. You all know how the sinus P wave looks like normally and in that patient. So if that P wave looks different based on some of the things what we showed, then make sure that you're not dealing with a PAC or something else. Consider a ladder diagram. And ECG is so beautiful and so charming that try to correlate ECG with try to correlate physiology with the ECG pattern and not the other way around. So don't go by pattern recognition that, oh, group beating means almost always means Venky Back, or sinus bradycardia always means hypothyroidism or high vagal tone. The physiology is so beautiful that based on the ECG, a lot of times you will be able to figure out what might be going on with the patient, and that can help you make the diagnosis. Like in the hyperkalemia ECG, what we saw, acute MI ECG, what we saw. So, just try to focus on physiology and the ECG pattern. The ECG will start talking to you and tell you what is going on the ECG. So I'm sorry for being a little bit late, and I think I'll stop here. If you have any questions, concerns, feel free to message me, or I'm happy to take any questions. Thank you.
Yeah, before we go to the next session, there's a quick question from the panelist. And in between, Dr. Rafique, I would request you to please be ready for the presentation. Before I go to Professor Rafique, I have one question from panelists that in case of CHB in acute anterior MI and early revascularization or reperfusion, how much possibility of reversion from CHB from Professor Ashok Datta?
So it is very difficult for the complete heart block to really recover, because if your His, which is getting, so this is your His bundle, if this is infarcted, the next escape is going to be from the ventricle. And His only has single blood supply, which comes from the septal perforators. AV node will have obviously blood supply from the posterolateral, but the distal half of the AV node and the His bundle are actually supplied by your first septal perforator of the septal perforators. So if the septal perforator is down, so all this area is down, and then you are going to have intrahissian disease, and that's really not going to recover. So rule of thumb with complete heart block anterior wall MI, they will majority or probably all of the time will end up with a permanent pacemaker. Inferior wall MI, rarely patient will get a permanent pacemaker.
Thank you, sir. Thank you.
Can I make some comment?
Yes, sir.
Yes, sir.
Okay. Dr. Deshmukh, wonderful lecture. I mean, bradycardia, I think, is the most difficult lecture to give because it seems like a simple topic, but it's very difficult. One question, the patient that you presented that had a nighttime pause, which looked like sleep apnea. The patient that one of the ECG with nighttime pause and bradycardia, which was thought to be sleep apnea.
Yes.
The problem is if the same patient presented with syncope and you get the nighttime pause, which we think it is sleep apnea, what do you do?
I know it's a tough clinical question. So let me just show that ECG, and so we'll know what Dr. Rafique is saying here. I swear I've seen it. Yeah, this one. So if this patient has syncope again, we have to really figure out why the patient is having syncope. If we truly correlate that the syncope was happening because of bradycardia or then we are obliged to give him a pacemaker. But if the bradycardia is only happening at night and they are not having syncope, then it is concerning. The trick I use in these patients is that if the heart rate is slow, they may also have supine syncope. So they may be like sleeping and they may pass out while in the resting position, they may have syncope and be very, very difficult to arouse. That can be some clinical clue which can be used. But a lot of times it becomes a judgment call. If the patient is kind of older and despite treating the sleep apnea, you're still having these pauses, then you may consider a pacemaker, but becomes a hard clinical decision.
Yeah, I totally agree. So the reason I brought up this issue is it is not an easy answer. And it is not also easy, straightforward pacemaker implantation. I think yes. What Dr. Deshmukh said, and we do the same thing, that let's say if this is a 55-year-old male with history of syncope, then we have to correlate the bradycardia with the symptom. And we have to wait a little. If there is an 85-year-old recurrent syncope, and the other question that was made, supine syncope, which we never know if the patient really passed out while lying down or not. So please remember that in your clinical decision making, that age is a factor in it, and straightforward pacemaker is not something that we should jump into, and we should spend a little bit more time on correlating symptom. The other ECG that I always get consult, I'm sure you do, is that pseudosinus bradycardia.
Yes.
And there is a lot of pressure on to put pacemakers in these patients from cardiologists. Do you agree with that?
I 100% agree with you. But then we have to discuss whether we have to treat the patient or treat the ECG or treat the telemetry or treat the referring doctor. Because if it is pseudosinus bradycardia, you're not going to make the patient feel better. Whenever we start doing things when we are not supposed to do, we end up with complications. And we just have to sit down with the referring doctor or the nurse or the student who is looking at the telemetry and try our best to convince them that this is pseudosinus bradycardia or this is pseudo bradycardia, and the patient does not need pacemaker. You might all have seen it takes a longer time to consult to say the patient does not need a procedure or does not need a pacemaker than to have a consult to say, well, next step is to get your pacemaker. That's straightforward. But when not to give a pacemaker, that becomes a true, the challenge, and that's where the doctor in the cardiologist or the electrophysiologist shines. If you can convince somebody not to get something done.
Absolutely right. I've spent 2-3 hours on this. I could have put a pacemaker in 45 minutes, but exactly. I think investing that 2-3 hours is important on our part to convince. And the same thing happens with ventricular bigeminy.
Yes, or even vasovagal syncope,
Yes, so those are the issues that putting a pacemaker straightforward is not a solution, but spending more time and trying to correlate the symptoms. Thank you. This is a great lecture.
Thank you. Thank you, Dr. Deshmukh. Now I would request Professor Rafique to kindly share your screen. And we are very, very thankful to each one of you, those who are seeing the program. I can see almost 200 participants are live here, along with our all the panelists. So over to you, Professor Rafique.
Well, I think we should make this a little shorter this time, my part, because it's getting late in Bangladesh. For me, it doesn't matter, but we will make quick. This should be shorter.
So for Bangladesh, they are absolutely with all of you. So please carry on. They are almost, I can see, more than 215-20 people.
So my lecture is a little bit repetition. We have done bits and pieces of it before. So tachycardia, what the ECG tells us. As a matter of ECG never tells us anything. I ask the ECG, what do you want to say to me? And it has been nicely presented by Dr. Deshmukh that you look at the ECG and you look at the T wave. Is there any distortion? Is there something there? Is it repetitive? Is it an artifact? And those are the kind of things we always struggle with. And that's academic exercise, keeps our brain going. So we'll skip that. Tachycardia, two types. Wide QRS, narrow QRS, we all know. Wide QRS is mostly VT. Narrow QRS SVT, even though I made SVT, but it can be also VT. There are ventricular tachycardia, which is narrow QRS. I'm not going to go into this. I've shown this slide before. The mechanism of tachycardia, supraventricular, there can be re-entry in the sinus node, in the AV node, atrioventricular re-entry, macro re-entry, or micro re-entry in the atrium, causing atrial flutter, atrial tachycardia, and then, of course, atrial fibrillation. And all of these conduct through the AV node and produces a narrow QRS complex. A narrow QRS tachycardia, we should never forget sinus tachycardia because patient comes to the hospital with fever, has a heart rate of 125, and we can't see the P wave clearly. It can be sinus tachycardia. Then, of course, the other arrhythmias that we have mentioned in previous lectures. Ventricular white QRS tachycardia can be ventricular tachycardia or SVT with pre-existing bundle branch block, antidromic atrioventricular reentrant tachycardia with WPW syndrome, and SVT with aberrant conduction. All those are the possibilities. So this is one ECG. This is a heart rate of about 136 beats per minute. And of course, you can clearly see the P wave, and which is upright in lead 2, 3 AVF. And Dr. Deshmukh said in lead V1, you can see biphasic P wave with initial positive, negative. So it's clearly sinus rhythm and it's sinus tachycardia. So what happens? This one, I've shown this ECG before. It's a tachycardia with a rate of 121 beats per minute. Now it's a little difficult. I have to imagine a P wave somewhere. And I'm thinking that in lead 1, this notch, the negative notch is the P wave, or is it the positive? It can be any one of those, but the positive part looks a little sharper than the negative part. Probably that's the possible P wave. And if that's the case, it's that the RP is little shorter than PR. So shorter, but almost in the middle. So what is this? The same patient, when the rate goes down, you can see that the patient has first degree AV block. So what patient had that was first degree AV block with sinus tachycardia and made the whole thing confusing. And if we give this ECG, single ECG, we have to entertain all the possibilities that we talked about in reentrant tachycardia, atrial tachycardia, all those possibilities. One of the things that I always talk about is if the patient is on telemetry monitor and the heart rate is all the time for minutes and hours on 121 beats per minute, that cannot be sinus tachycardia. Sinus tachycardia will fluctuate. It will be 121, 123, 118. So because there is respiratory variation, even in the setting of tachyarrhythmia, that will be one clue to differentiate between sinus tachycardia and other form of reentrant tachycardia. We have shown this slide before. The position of the P wave is important. If the P wave is buried in the QRS complex, we cannot see any P wave, and it's most likely AV node reentry. If the P wave is immediately after the QRS complex or immediately before, within 80 milliseconds, it's most likely AV node reentry. Can also be an atrioventricular reentry with a concealed pathway closer to the AV node. And then, of course, if the RP interval is longer than PR interval, P wave retrograde is in the ST segment, is atrioventricular reentry. And then we have long RP tachycardia. And depending on the morphology of the P wave, it can be atrial tachycardia, sinus tachycardia, atrioventricular reentry, or atypical AV nodal reentry. And these are all the possibilities that we need to entertain. So coming back to this is my sinus tachycardia ECG. That's a long RP tachycardia with a positive P wave in lead 2-3 AVF. That makes it sinus tachycardia. How about this one? This is again a long RP tachycardia, heart rate of 133 beats per minute. So it is either a sinus tachycardia, atrial tachycardia, atrioventricular reentry, atypical AVNRT. But this P wave is inverted in 2-3 AVF and also in V4, V5, V6. So it's clearly, I mean, it's almost certain that this is an atrial tachycardia originating from the left atrium. How about this one? Now this becomes confusing, and this is where we need to bring in some imagination. Heart rate is about 170 something. And if I look in lead V1, it is difficult to say where is there a P wave or where it is. I can imagine maybe there is a P wave where this negative component is. One place that I thought maybe there is a P wave is lead 3. It looks like a funny looking distortion of the T wave, little bit positive followed by negative, and it's consistent. And if I do that, this is a long RP tachycardia because RP is longer than PR. So that will put, again, it becomes the same thing that is it atrial tachycardia? It can be an atypical AV node reentry. I don't think it is sinus tachycardia because if the P wave morphology is this, like biphasic in lead 3, probably is not. And this patient, when we gave adenosine, you can see that clearly the P wave comes out and the tachycardia doesn't stop, clearly makes the diagnosis atrial tachycardia. It cannot be atrioventricular reentry because atrioventricular reentry cannot happen without presence of a QRS complex. We can see AV node reentry without QRS complex, but with this amount of adenosine, this degree of AV block, to have this AV node reentry continuity is very, very unusual. So that makes the diagnosis atrial tachycardia more likely than anything else. This tachycardia, again, narrow QRS tachycardia, its rate is a little bit less than 150, and there is a P wave immediately after the QRS complex in lead 2, 3, and AVF. Now, then if I look at lead 3 and AVF, it is can be difficult. I mean, if somebody says, well, maybe it's part of the QRS complex, but lead 2, this negative component is unusual to be part of the QRS. And of course, at this point, and then the other part that we sometimes look at, if you look at lead V1, there is funny distortion just at the end of the QRS complex. And it's probably not artifact because you can see it in every one of them. And this probably is a retrograde P. And if this is retrograde P wave, then this is most likely AV nodal reentry. And this is the ECG of the patient. After the adenosine, you can see in lead 2, there is this terminal negative component is gone. Lead V1, that funny distortion is gone. So that's where I think we were right, that this was retrograde. And that's how we learn. The way to learn is if I just have this ECG and gave adenosine and felt happy about it, I have not increased my knowledge. To increase my knowledge, what I did, I looked up the other ECG and then compared. Yeah, I was right. That P wave, that funny negative component was the P wave. And that we need to keep doing it all the time. Every time we do ECG, carefully look at it and also reconfirm my diagnosis. What we do even at my age, that sometimes I will have ECG, I will have a diagnosis, I'll send it to one of my colleagues. Hey, by the way, I am thinking this. What do you think? And he says, yes, this is what we think it is. And sometimes we also confirm our diagnosis during electrophysiology study, and that's how we reinforce our finding and knowledge. So AV node reentry, there is a slow pathway and fast pathway. If the electricity goes down through the slow pathway and then come back through the fast pathway, it can cause the reentry circuit and go down. But as Dr. Deshmukh mentioned, that why doesn't it happen all the time? Because normally electricity will go down the fast pathway and block in the slow pathway. And that's why you will not always get reentry. It will only get reentry only when it's a critically timed stimulus, which goes down through the slow pathway and can come back through the fast pathway, or the other way around. So this is another narrow QRS tachycardia. Again, if we use a little bit of imagination, I can see there is a distortion of the T wave. And so I'm thinking there is a P wave here. And where is the beginning of the P wave? Where is the beginning of QRS, ending of the, I can't tell that definitely, but I think there is a P wave, and because this distortion is present everywhere. And that makes it a,
Wadud Chowdhury
it's probably somewhere in the center. I'm not sure whether I can say definitely this is long RP or short RP, but if I look here, it looks the RP is shorter than PR. And this patient, after conversion, you can see clearly the patient has WPW syndrome. So definitely it is an atrioventricular reentrant tachycardia. So reentrant tachycardia, what happens? Goes down through the AV node and then comes back to the accessory pathway. Depending on how far the pathway is, it will decide how far the retrograde P wave is from the QRS complex. So if there is an accessory pathway very close to the AV node, it will almost look like AV node reentry. And that's when the confusion will start. Treatment is very simple. I'm just touch a little bit about the treatment. Treatment is acute treatment is adenosine. One of the things about adenosine is that when you give adenosine, you have to give it very fast. So I always connect a 3-way stopcock and connect to syringe. One syringe of adenosine, other syringe, it's a flash, about 20 ml flash. And if necessary, I will elevate the arm and inject it very fast. And otherwise, adenosine will wash out. A couple of days ago, there was a patient in the cath lab, very obese patient. Patient went into SVT during tachycardia, and they tried up to 18 milligram of adenosine through the peripheral line. Nothing happened. So we ended up putting a femoral venous line and then gave 6 milligram of adenosine, and patient's SVT stopped immediately. So this ECG, it's a white QRS tachycardia. The most confusing setting for this ECG is a 44-year-old male, non-ischemic cardiomyopathy, shortness of breath, palpitation, and this is the ECG. This is the ugly-looking white QRS tachycardia, almost concordant in V4 to V5, but except V4 is positive. And if I look at it, anybody would look at it and say, this is ventricular tachycardia. But what happens?
Professor Wadud, if you also can join here with Dr. Rafique with this ECG.
So then, if when the patient rate slows down, you can see that there is 2-to-1 flutter, and the QRS morphology is exactly same during ventricular tachycardia. So the presence of an older ECG helps in differentiating white QRS, even though the setting was really ventricular tachycardia. This was not ventricular tachycardia. This was 1-to-1 atrial flutter in the setting of pre-existing bundle branch block. And this is another patient that is a study that this was induced during EP study, right bundle branch block tachycardia, rate 219 beats per minute. And you can see the initial R, small r, followed by a bigger R wave. And that is suggestive of supraventricular tachycardia with right bundle aberration. And the patient actually had baseline right bundle branch block. So having a previous ECG is of help to us in diagnosing this white QRS tachycardia. How about this one? This one is a white QRS, rate about a little bit over 200 beats per minute. One feature of this ECG is that V1 through V6 is all positive. The concordant ECG in chest lead is very much diagnostic of ventricular tachycardia. So if we look at precordial concordance, then if it is yes, then it's ventricular tachycardia. How about this one? Now we have this another tachycardia. It's a white QRS in the V5, V6 left bundle type, but lead V1 not quite. So what do we look at? Another feature that from the onset of the R wave to the deepest point of S wave, if it is more than 100 milliseconds, and this ECG is like that. In the chest lead, if we look at lead V2, beginning of QRS, to the deepest point of S wave, it's more than 100 milliseconds. That suggests ventricular tachycardia.
Please mute everybody.
Is there AV dissociation? AV dissociation sometimes is difficult to see, especially as the tachycardia gets faster. But sometimes we can look for it. And like here, this ECG, that if we look at lead V1, a rhythm strip, there is a possible P wave here. And then there is another P wave here, followed by a bit, which is in between. It's a little bit different from the ventricular tachycardia. So that's a fusion bit. If we see AV dissociation and future and captured bit, that's 100% ventricular tachycardia. And these are observed, especially in the slower ventricular tachycardia, in the rate of around 120, 130 beats per minute. So if there is AV dissociation, that's ventricular tachycardia. And then we can use morphology criteria. We had a couple of sessions with that. So these are the different types. If the ECG is right bundle and it shows monophasic R wave or QR pattern in V1 or RS pattern in V1, that suggests VT. Along with in V6, if RS is less than 1, that suggests ventricular tachycardia. With left bundle type, if the initial component of the QRS complex is in V1 is more than 30 milliseconds, that VT. This hump in the wave, it suggests VT, and then QS QR pattern. And this is one ECG that this is a right bundle type ECG. But if you look at this, it is QR pattern in lead V5, V6, RS ratio less than 1. And so this puts it into a diagnosis of ventricular tachycardia. And this one is the other one that I showed, that this one, white QRS, this initial component of the V1 is more than 1 box. It's almost 60 milliseconds. That is more or less diagnostic of ventricular tachycardia. If the morphological criteria is present, it's VT. If that criteria doesn't fit, then it is SVT with aberrant conduction. I'm going to show a couple of more ECG and then stop. This is another ECG. Please be careful about this. This is the telemetry strip. Please make sure that you talk to the patient, ask if he's awake or not before you do anything about it. Because this is actually, if we look at the second strip, simultaneous strip done, you can see this is an artifact. It looks like fast ventricular tachycardia, whereas it was actually the QRS complex here. And if you believe me or not, people have been shocked because sometimes patients are connected to pads and external ECG, and the ECG machine is outside without talking to patient. Patients have actually given shock to patients. So you see this rhythm, go and evaluate the patient first before you do anything. This ECG has been shown by Dr. Deshmukh that you see bradycardia dependent. There is pre-existing long QT syndrome, but this PVC causes pause and then long QT. And the treatment is that you have to avoid the bradycardia, and then other treatment of torsade magnesium, take away the offending drug. And this patient had baseline QT prolongation. This was a patient who actually is one of my patients that had a pacemaker which malfunctioned and then developed bradycardia with long QT. And patient was on amiodarone for atrial fibrillation. Again, the treatment is not defibrillator. We just fix the pacemaker, continue amio, and she did fine. This is a white QRS tachycardia. This is a very ugly looking ECG, but one character is this. If we look at lead V1, these QRS complexes are multiple different width with irregular RR interval. I always tell people that if RR interval is irregular and QRS duration is irregular, always think of atrial fibrillation in the setting of WPW syndrome. This is a slightly better ECG to see. Again, irregular RR interval and irregular QRS duration. And this same patient, this is ML, when you convert to sinus rhythm, you can see the pre-excitation. Best treatment for this is IV procainamide. Unfortunately, procainamide is difficult to get, and the second best choice probably would be to use amiodarone. And if the patient is unstable, we can shock the patient. And the same patient after radiofrequency ablation develops normal QRS complex. I think we're going to stop here. Yes, thank you very much.
So I would request Dr. Wadud, Professor Atahar, and if you can unmute yourself, and over to you, Dr. Wadud.
Rafique sir actually started talking about arrhythmias and other things long ago, and in the last few weeks we have had beautiful presentation from him on different aspects of why arrhythmia occur, how to differentiate between the so-called what comes the tachycardia that's actually not from the ventricle itself, and etc. And this is actually, as he has taught us, look at the ECG, lots of ECG, and try to understand what is happening. And only then it will be imprinted in your mind what to look for, how to look for, and how to differentiate one from the other. And today's lecture, though because of the shortage of the time, he's actually shorting it, but I do think we'll be getting again and again beautiful lectures from him to learn much more from him. Thank you, sir.
And I request any other of the panelists, if you have any question for Dr. Professor Rafique and Professor Abhishek, both of them are live and they are ready to any sort of queries if you have.
Sir,
Sir.
there is a question. There is a question in the chat box. That is, why in infrahisian block this block worsens with atropine?
Good. Can you hear me?
Yeah, little bit
Okay.
louder, sir.
Okay. Can you hear me better or no?
Better.
Okay, good. So again, SA node, AV node, his right bundle, left bundle, and the block is here now. So atropine or anything else is going to make this AV node start to work faster and faster and faster. If the block is below the AV node, then all these impulses are coming at a much faster rate from the AV node down to the his bundle. If the his bundle is diseased, then that even gets more fatigued. And from like an intermittent heart block, it will become complete heart block, or from complete heart block, it will become asystolic. So that's the reason for infrahisian block or intrahisian block, the recommendation is not to give atropine.
Thank you, sir.
Sir,
For the panelists,
sir, I have a
Dr.
question
Tushar, please.
to Rafique sir. Sir,
Please ask
Rafique
your
sir,
question.
assalamu alaikum.
Yes, sir.
Sir, why during white complex tachycardia, irregular white complex tachycardia, we see the QRS amplitude is quite high. When it convert to sinus rhythm, the QRS amplitude is not that much high. In WPW, during sinus rhythm, the QRS amplitude is not that much higher. But during if you with irregular white complex tachycardia, the QRS gets quite higher. Why that so?
Well, I mean, it's the question is why the QRS during AFib with WPW syndrome, right?
Yes, sir.
The
Yes,
QRS,
sir.
it's the same as PVC. So if you look at ventricular premature beats, their amplitude is higher because the conduction is through the normal myocardium, and as opposed to the conduction through the muscle. So when is WPW syndrome, the conduction is exactly like ventricular premature beat. It is not happening to normal part.
Yes, sir, but
any Dr. Desbook has any input on that?
Sure. So, again, the way one would think about this is, sorry, I just keep on showing this whiteboard again and again. Can you see the board?
Yeah, we can.
Yes, we can
Good.
see.
So activation goes from sinus node, AV node, his bundle, right bundle, left bundle. The reason, so when your activation is going down the bundle branch block, there is no QRS activation. And the QRS activation happens when you finally have this wave front exiting on the myocardium. And that's why you get a QRS like this. In WPW, the pathway is somewhere here. So it is bypassing the AV node. So your activation is going from the atrium straight to the pathway. So if you look at a normal QRS, you almost always have this sharp DVDT. So this downslope is very sharp. And as Dr. Rafique showed in the example, if this downslope becomes quite wide, that is one of the markers you think of VT. Same principle applies in WPW. Because the AV node, his Purkinje system is bypassed, the ventricle suddenly gets activated without going through the AV node. So this part of the his Purkinje system, which tries to make the QRS more rapider or the DVDT more sharper, is avoided or is bypassed when you're going over the accessory pathway. So because the ventricle gets depolarized right away, straight away, without going through all this, the QRS amplitude sometimes looks, most of the time looks quite larger. Same principle again, why we should never call left ventricular hypertrophy when somebody is having a pre-excited rhythm. We don't call left ventricular hypertrophy based on a PVC morphology. We call left ventricular hypertrophy based on the normal QRS morphology. It all depends how the ventricle gets activated. If the ventricle is getting activated bypassing the his Purkinje system, the QRS almost always looks quite larger because there is no balancing of the vectors which happens by going down the right and left bundle. I hope it was, if I answered it right or happy.
Can I add on something?
Yeah.
Look at the normal pathway. It's going down from the atrioventricular node to the right bundle and left bundle. The right ventricle is depolarizing along with the left ventricle, but two current are going opposite side. The one is undercutting the other, so the amplitude gets smaller. But when you are bypassing through the, in case of WPW, in another pathway, the negative factor, the negating factor is not there. So you are getting a bigger complexes.
It's only one vector.
There is not two opposite factors working simultaneously. One is activating much earlier, the later on some other thing.
Because the QRS is a summation of RV and LV activation, the normal QRS. But a pre-excited or a PVC is just activation of that part of the ventricle where the thing is coming from, for a PVC or pathway from where the ventricle is getting activated. Great. Very good.
Thank you, sir.
Thank you. Thank you so
Um,
much, sir.
Deshmukh.
Yeah, Dr.
Yes,
Dr.
sir.
Atahar Ali, please.
Hello, Deshmukh.
Yeah, we
Yes,
can
sir.
hear you, sir.
In case of the six sinus syndrome, sometimes we see the one sinus beat, one escape beat, one sinus beat, one escape beat. Can it be called group beating?
So group beating is
sorry.
So group beating is a pattern when you have a group of beats happening, either group beating of P wave, group beating of QRSS. So group beating is kind of a layman's term. So, we have to be more specific whether the group beating is because of SA exit block or Venky Back or block at the level of AB node. So, so group beating is kind of a layman's term when they say an ECG and they see beats in a group, that's about it. But from our standpoint, people who are going to go deep into the ECG, you're going to start looking at where the level of block is. So I would not call that.
One question is there to Rafique sir. Is there any difference in SBT with bundle branch block with SBT with aberration? Dr. Parthu was asking that.
Oh, the question is there any difference between SVT with bundle branch block, SVT with aberration? But it is the same. Let's take an example that a patient has pre-existing bundle branch block, and we get the left bundle branch block pattern, SVT. Same patient can have tachycardia dependent bundle branch block and will develop left bundle. So when this happens with change in rate, we call it an aberrant conduction. It's just an old term. I mean, we have been using that there is the aberration of conductor. But I think the better term is rate dependent bundle branch block in this in this kind of situation.
And actually, you can identify that only after turning into sinus rhythm, whether this is this or that.
Thank you, sir. Another question for Rafique sir is how to differentiate between sinus tachycardia with first degree AB block and versus atrial tachycardia.
Oh, yes. I mean, that's the difficult. So it becomes difficult. Let's say I have an atrial tachycardia at a rate of 120 beats per minute. How do I differentiate? So the situation, first of all, to be sinus tachycardia, patient must be in that situation. Either patient is very sick, patient is febrile, patient is hyperthyroid, or patient is running. So that's one clinical scenario. If somebody is a perfectly otherwise healthy young individual, 25-year-old, with a heart rate of 121, that is unusual. Second, I always look at the heart rate variation. Is there any variation? If somebody is really fixed at 120 beats per minute, 125 beats per minute, then it is unlikely to be sinus tachycardia. Then, of course, the morphology of the P wave. But you have to be very, very careful about the morphology, because let's think about right superior pulmonary vein. If there is an atrial tachycardia coming from the right superior pulmonary vein, it may look exactly like sinus tachycardia. And so you have to use combination of all these factors in identifying this. I actually had a young patient who had atrial tachycardia, and the rate will vary a little bit. She will, sometimes she'll have heart rate of 130, sometimes 140, 150. Initially, we thought it was sinus node reentering tachycardia, but at the end we found out it was actually an atrial tachycardia coming from right superior pulmonary vein, patient got ablation, her cardiomyopathy improved, she is free of any symptom. Dr. Deshmukh, can you comment on this?
No, it is fairly common that somebody gets labeled as inappropriate sinus tachycardia and we blow them away, and then actually they may have atrial tachycardia. So couple of clues would be, is it sudden start, sudden onset, sudden offset, or is the patient in it all the time? Then the P wave is helpful, but again P wave has some limitations because if it is coming from areas around the sinus node like RSPV, Crista tachycardia, they all may look somewhat similar. Heart rate variability is important, but main thing is just put on a Holter. See at night if the heart rate goes down, that is going to be mostly sinus tachycardia or sinus rhythm. Heart rate remains rock solid despite whatever you do, that is going to be atrial tachycardia. One clue which can be done sometimes is to give adenosine. Sinus tachycardia will not terminate. Atrial tachycardia may also not terminate. Rarely it can terminate, but you can look at the P waves better if there's some confusion when the P waves march out with an AB block. And lastly, extreme situation, you can consider a cardioversion, because you can't really shock somebody out of sinus tachycardia, but you can certainly shock somebody out of atrial tachycardia. But even before you cardiovert, with the sedation, what you give for cardioversion, that itself will tell you the clue, what's really going on. Certainly beta blockers, diltiazem, all those things can be used, but a lot of times, as Dr. Rafique said, it's a clinical diagnosis. So that's why when we are treating the ECG, you have to treat the ECG and the patient both together, not one in isolation.
Dr. Abhishek, this is Professor Mohsin Hussain, NICBD.
Yes, sir.
You told a patient with NRMI and complete heart block, all patients need pacemaker. But we have seen a lot of patients, they revert from sinus rhythm, complete heart block to normal sinus rhythm or anterior post-fascicular block. Do you suggest patient with residual fascicular block or normal rhythm? Do you suggest the patient with pacemaker?
No, so if the AV conduction has improved, then obviously there is no indication for pacemaker. But again, really depends on which septal artery gets compromised. If it is a very, very proximal septal artery which got compromised, and then there is flow there, maybe the patient got lucky and the conduction improved. But the fact that your patient had left anterior fascicular block, that means the block was maybe a little bit more distal to affect the diagonal arteries and all that. So those kind of complete heart blocks may improve. But if you get a complete heart block, infraescient disease with anterior wall MI, the patient is fortunate if the AV conduction improves.
If no fascicular block does not have it need any pacemaker?
No, just for a fascicular block, you don't need a pacemaker.
Thank you.
So one question to Deshmukh.
Yes, sir.
Hello, sir. Actually, it is a case scenario.
Yeah.
A patient of 42 years old.
Yeah.
ECG that is as a part of the pre-employment health checkup, he underwent the ECG and that showed the complete heart block. I have seen that is a complete heart block. Heart rate is around 38. The QRS is RV morphology. The patient did not give any symptoms. Whether we should do the pacemaker this patient, or we should that is less than 60 years old, or we should do that is a further investigation to see the other, that is the patient does not have any symptom, asymptomatic patient. The patient did not show any previous issue, whether it is congenital or I don't know.
Yeah. So certainly, patient needs more detailed evaluation, echocardiogram, make sure there is nothing going on, ejection fraction, all that. One condition which a patient, can go undiagnosed and may present later with complete heart block is a congenitally corrected transposition of great arteries. So, they may be born with that. RV is where the LV is where the RV is, and they are at a higher risk for complete heart block, maybe completely asymptomatic, and suddenly later in life, they get noted to have this. Certainly throughout sarcoid, infiltrative cardiomyopathy is important. But assuming everything is normal, everything has been done, then congenital heart block can be there. But again, congenital heart block is not that straightforward. Generally there is a school of thought which says don't give them pacemakers. But if it was your own brother or brother-in-law, you would think very, very strongly about giving them a pacemaker with complete heart block. Other thing is we have to be very, very sure whether they are truly asymptomatic or not. So a lot of people get used to being, having a bad back or a bad knee. You just learn to live with it. So same thing happens with complete heart block. And you may potentially, pace them and they may start to feel a little bit better. But personally, I'll be very, very hesitant not to give them a pacemaker, especially with complete heart block, especially when you said right bundle pattern. So there's a concern for both maybe infrahiscient disease also with the bundle branch block. So I'll find reasons to give him a pacemaker. So, and again, no employer is going to hire him if he has complete heart block, right?
Right.
Dr. Deshmukh,
Yes,
one
sir.
question from Dr. Rafique Ahmed. Is it contraindicated to use some drugs that causes QT prolongation like azithromycin or antidepressant in a patient with bradycardia?
It's a good question. It's hard to know. It also depends if the patient is having PVCs and all that. So azithromycin, levofloxacin is not going to cause bradycardia per se, but all these medications are IKR blocker. So it's going to block the rapid rectifier potassium channel. So again, if I can just use this board again for a second.
Yeah. Can you take a little bit closer mic because the voice is going
Yes.
down?
Can you hear me?
Yeah.
Yeah. So P wave, QRS, and T wave. The problem is that you don't want to have a PVC which is happening on this part of the T wave, which is going to set off torsades. Now, IKR basically codes for the tip of the T wave, IKR channel. So if you have an IKR blocking medication, your T wave looks little bit notched like this. So if you guys have time, maybe Google ECGs on patients who have dofetilide or patients who take methadone or toxicity related to, I can't see my screen.
Yeah. Now it's fine. So please go ahead.
Yeah, toxicity related to dofetilide or methadone or any of these QT prolonging medications. QT prolongs, but the T wave becomes quite notched. Again, you Google it, and I don't have an ECG right now to show you. So then that becomes concerning. If you have profound IKR blocking effect and the QT prolongs, then you're just waiting for one bad PVC to happen to set off PVC triggered VF or torsades. Generally, if you're not having any PVCs, they should not per se cause torsades or VF. And again, you have to watch them very, very carefully to make sure that they don't end up in trouble. Can even consider in-hospital try of these medications if somebody is like profoundly bradycardic.
Rafique sir, do you have any comment on that?
No, I think well answered. But I think this bradycardia session, please, I hope everybody is paying attention to this. The bradycardia is so important. Patient comes to the hospital with syncope. Just because you find a bradycardia does not mean they need a pacemaker. Especially watch out for nighttime bradycardia. That is very, very important. We rarely use nighttime bradycardia and falls as a cause of to implant pacemaker. Not that they don't need it, but please make sure that you confirm symptom and correlate with the bradyarrhythmia.
Can I have a question?
Sure.
To Professor Rafique sir. Sir, the ECG that you have showed where the patient was having atrial tachycardia and a heart rate of 122. Particularly in that ECG, I can see that the P wave is in between two QRS complex. And there was old school saying that if P waves lies between two R wave, that is the Bick's principle, then there ought to be a P which is buried within QRS. Is it still hold the truth?
Well, yeah, go ahead.
You are suggesting 2:1 conduction.
Yes, sir. The Bick's principle says when the P wave is in between, is just in between two R waves, then the other P wave is ought to be buried within the QRS complex. That is what the Bick's principle.
I understand what you are talking about. So if the question was that if there is a P wave just right in the middle of the QRS, is there another P wave buried in the QRS complex? It's a possibility. I mean, we have to entertain that. This happens even with diagnosis of atrial flutter, or that you always look for a second QRS complex, and that's where the monitoring is important. I mean, so if the P wave is right in the middle, center of two RR intervals, one of the tachycardia that I showed was a clear P wave that was not in the middle. The one that was sinus tachycardia, that I had more ECG on that patient. I could gradually, there was a gradual shift of the P wave. But that's a great point that a P wave in exactly in the middle of RR interval, please think of another P varied in the QRS complex, which is as a 2-to-1 heart block.
Sir, I have one more question. One more question, sir. Maybe it sounds silly. Can we differentiate between Mobis type 1 and type 2 when we have 2:1 block, 2:1 AB block? In patients with 2:1 AB block, can we differentiate between Mobis type 1 and type 2?
I leave that for Dr. Desmond because that was his topic today.
Yes, please.
So type 1, you will have PR prolongation. They don't have 2-to-1 AV block. They will have this group beating. So PR will get on longer block, and then you will have the next PR is going to be shorter. So ideally, typically they would not have, for typical Venky Back, what we see, you should not get 2-to-1 AV block for basic understanding. But there are so many different levels of blocks also. If you have more time, we can go over it sometime. There is something called as multi-level AV block. The top half of the AV node can be in Venky Back, the bottom half may be in 2-to-1 AV block, or block between the AV node and the His bundle. The AV node may be 2-to-1 AV block, but the His bundle may have Venky Back. There are various different kinds of multi-level AV block and atypical AV blocks, and some of these phenomena can be explained based on that as well. But and if you have interest, we can do a separate session on that, just multi-level AV blocks. We see that in flutter with rapid irregular rates, atrial fib with irregular rates. That's all an example of multi-level AV blocks, but I think it is a bit too much to explain at this point, sir.
So I would
Thank you, sir.
I would rather request Professor Wadud.
I think we are having a very wonderful session by this.
Absolutely. So Professor Wadud, if you have some question for them, and other doctor, those who all are in the panel, it's the time. I know that it's almost 10:40, and I'm extremely glad to see almost 150, more than 150 participants are live and they are watching in front of the screen. So any question from the panel before we go to the conclusion to Professor Wadud and Professor Atahar?
I think Professor MG Azam is trying to ask a question.
Yeah, Professor Azam,
Professor
you
MG
ask
Azam,
something.
please.
Go ahead,
Yes.
please.
Thank you. Actually, I face a problem for last 3 days. I think this is the wonderful gathering where I can share my problem so that I can rescue my problem. Actually, the last Wednesday, a patient came to our hospital with acute estimation AMI with complete heart block, antroseptal AMI with complete heart block. But this night, patient was thrombolized. Following morning, we go for angiogram because patient has complete heart block with antroseptal AMI, patient getting already thrombolytics. Then we go for triple vessel disease, proximal LAD, distal SARC, and proximal RCA. So, as you see, this is thrombolytics is given. So we thought revascularization may be help. So we did accordingly, but this is today's start day. Now patient is heart rate is 56, but we just off the TPM. Now 56 in sinus rhythm, but actually what should we go for next step? That is my any recommendation from Dr. Abhishek.
So
or any volunteer expert panel. It will be very helpful for me.
How is the PR interval?
I just can't remember, but PR interval is, I think it is within normal limit.
Normal limit, okay. And what is the ejection fraction?
It is before, after procedure, the following day, patient initially it is totally dependent.
Yeah.
After second day, patient, we just try to rate, stop, and try to either the patient is a sinus or not. Then patient become 56 per minute rate.
Any update about EF, ejection fraction?
Sorry, EF.
Yeah.
Ejection fraction. Yeah,
Yes, sir.
today we didn't. Tomorrow we will plan for this.
Yeah. So I think if the patient's AV conduction has improved, so causes of heart block in acute MI, apart from ischemia to the conduction system, is also this basal gyrix reflex, is also the medicine what we give, sedation, autonomic changes and all that. So if the conduction has improved, I would just wait and watch, maybe monitor him a little bit longer in the hospital, can consider like a 30-day monitor to make sure that, there's no, AV blocks at home. but hopefully he should do well. There's also an entity called as reperfusion bradycardia. So if the patient can also develop bradycardia, complete heart block after TPA or after thrombolysis as part of reperfusion bradycardia. So if the patient has gotten better, I think, maybe we should avoid a pacemaker in him.
So your recommendation, we should wait for
Wait,
the clinical course, right?
Yes, yes.
What clinical course?
Watch him for 3-4 days more in the
Because as you
hospital.
know, ST elevation MI and enteroceptal MI setting. Sorry?
Yes. Maybe you can watch him for 2-3 days more in the hospital once he's stable, make sure the conduction is getting better. And if the PR is getting longer or if the bundle branch block changes, then we may revisit this again.
Thank you very much.
So for the sake of the time, I would request both of our organizer, Professor Wadud and Professor Atahar, one comment from each one of you for both the speakers.
Atahar bhai, would you please?
Actually, I like to congratulate, thanks both the faculties, particularly Dr. Abhishek Deshmukh and Dr. Rafique Ahmed sir. Really, it was a wonderful session. I personally learned a lot. Personally, I think our all participants has learned many things, and I personally I am very much benefited. And I have learned a lot. It was a really great, memorable session. I think it is recorded, and our participants, when they wish, they can enjoy this whole video. So from my side, I like to congratulate and thanks both the faculties, and I want that in future we will arrange again such a type of things, and our participants are already requesting us, so that Abhishek Deshmukh and Rafique Ahmed sir is always with us, and I like to request Dr. Abhishek Deshmukh, when we want, and if we have got the time, our participants will enjoy your session. So thank you very much, Dr. Abhishek Deshmukh, and it is Professor Wadud Chowdhury. You just to give the thanks and conclusion.
Dear audience, it's quite late, but still I think we are really enjoying it. But we have to stop now and wait for the next session that will be coming. I have to thank our new guest, Dr. Abhishek Deshmukh. We have really enjoyed it, and I hope you have also enjoyed our companionship, and we'll be having much more of that in future, I hope. And Dr. Rafique sir is our own. So we always claim that he's of the son of the soil. So he's always with us. And what can we say? As I have already mentioned, he's the founder of the electrophysiology service of this country. And he can claim that honor, and that's rightly his. So we have to thank again for this wonderful presentation and the answers you have given to many questions. I have to thank Biopsy and all the persons involved from there, and also Syncope Pharma, who have given us the technical help for conducting this session. I have to thank all the faculties, all the panelists, senior teachers, both from medicine and cardiology, who are here at late this night along with us to enjoy this session. Your presence inspired us, and I have to thank the audience, the students, the doctors, the residents who are with us enjoying the session and also giving us the thoughtful questions. I have to thank the participants who have participated from abroad, from Nepal, Professor Arun Maske and his students, and some of the participants from India, and also I think some from Sri Lanka. Thank you everyone, and let us hope we can get this type of situation, this type of occasion again and again, so that we can all enjoy together. Thank you, sir.
Thank you, Professor Wadud, and thank you all of the people. One thing I would last comment, that ultimately the greatest lesson that COVID-19 teaches the humanity, that we all are together. So once upon a time, we used to think when we can get such a faculty like Dr. Rafique and Dr. Deshmukh. With the help of this internet facility, we can access them, regular fashion, and we learn a lot of things. End of the day, it's extremely important that from this lecture, from their vast knowledge, we can get something and we improve the quality of life of the patient. So thank you very much for the powerful presentation and wonderful discussion. Thank you and good night to all of you. We'll tune in another in next
very
program.
much.
Thank you.
Thank you, Rafique sir. Thank you, Deshmukh.
Thank you, sir.
Good night, everybody.